Okay, I want to welcome everyone to this virtual open house. My name is Dr. Ted O'Connell. I'm the program director at the Kaiser Permanente Napa-Solano Family Medicine Residency Program. Thank you really for taking the time out of your busy schedule to learn a little bit more about our residency program and our people. The goal with these virtual open houses is really to try to provide you with as much information as we possibly can about our residency program and our people. We certainly understand that this year is a unique experience applying for residency programs without being able to come on site for in-person interviews and even the difficulty about not being able to have second looks. And so this is our attempt to provide you more information about our curriculum and allow you to get to know our people a little bit better. I encourage you during this session to go ahead and use the chat function. We'll be monitoring that and we'll try to answer your questions as we go along. And then we will also provide the second half or so of this session as Q&A, and we'll dive into the chat function to make sure that all of your questions get answered. Today's topic, we're going to be talking about women's health and office-based procedures. We actually have a number of facilitators who are going to go through our curriculum and then help answer the questions. The first is Dr. Gabe Flaxman, who is a family physician. He's fellowship trained in obstetrics and does surgical OB when he's up on the labor deck, and is the director of our women's health curriculum. Dr. Kathy Holder is a family physician who does OB as well. She's actually up on the labor deck as we speak. So she says she's available, but potentially could get called away should she be needed for clinical reasons. Dr. Patrick Lowerre, also a family physician and member of our faculty, who does full spectrum outpatient family medicine and works up on the labor deck as well. Dr. Becky Render, who's a family physician, osteopathic physician, does OMT in her practice, and is the one who really helped develop our prenatal care curriculum. And Natalie White, who is one of our first-year residents, just finished up her first OB rotation a couple of weeks ago, so hopefully can give you some perspective with regard to her experience there. Dr. Aime Castillo is one of our third-year residents, chief resident, and has been through much of our curriculum and can give you good overview of any particular questions you have there. And I think I've captured everybody who's helping to facilitate this. If I did not, I apologize. And if any other residents joined, and I don't see you in the participant list. So I think we've got everybody. So with that, I will hand this over to Dr. Gabe Flaxman to start taking you through our curriculum.
Okay, hi everybody, thanks Ted. I just want to make sure first, Ted, will you give me a thumbs up you can hear okay? Okay, great. So as Ted said, I'm a family doc. I did an OB fellowship, and so I coordinated both the OB and family planning curriculum and women's health curriculum here for the residency program. I have just a very few slides to answer some of the questions that I think everybody has, but we certainly want to make sure we have a chance to answer any questions you have, either through the chat or as we're monitoring the chat, we can read them out loud or you can ask directly. I'm a total Luddite, and this is my first Zoom hosting anything, believe it or not. So bear with me if I mess anything up, and just please feel free to ask. We're going to focus mostly on women's health procedures, office-based procedures, and not so much on OB. We are happy to answer your questions about OB if they come up, but we have a whole other dedicated Zoom to OB. So with that in mind, we'll move forward. So we were kind of hoping that you get an idea of the structure of our curriculum after today and understand a little bit more our commitment to GYN care as well as family planning, and how we have some overlap and differences from other family medicine programs around. And most importantly, have a chance for you to get to know us or ask any questions that you have. So our mission statement, for those of you that haven't seen it or just to get a sense, is long. I think it's really fundamental and core to our program. But most important, our goal is to train full spectrum family physicians. And that includes full spectrum care and also some cutting edge and novel approaches to things. And we'll talk a little bit about those too. in terms of routine GYN care, there's in our family medicine center in the clinic here, we do cervical cancer screening, contraceptive counseling, and provision, endometrial biopsies. And we have a GYN procedure clinic every Friday afternoon. It's for residents all 3 years. It's weighted a little bit towards second and third years. The rationale for that is we wanted to be able to have residents not overwhelmed by the volume of patients. And so while I'd love to have an intern in the clinic all the time, we do a little bit less time with the interns because I don't want them to be overwhelmed by 7 procedures in a half day. And so I think the interns do 8 or they do 2 sessions normally, and then the second and third years do 4 each. And then there's in this procedure clinic, which is specifically for IUDs or lost IUDs, implant removal or placement, endometrial biopsies, vulvar biopsies, miscarriage management, including office-based manual vacuum aspirators. We are in the process of moving medication abortion into our family medicine clinic and incorporating it into the routine care in the office. This was all set to go, and I'm sure you guys have heard this a lot with excuses about COVID, but like we were ready to go in last January, February, and then poof. Not for any reason other than we've been kind of just grappling and adjusting our systems, but that is on the high priority list for this year to get that reintegrated. In our 2 month, the residents rotate in women's health and do all the same things as they do in our family medicine clinic, mostly with gynecologists and a couple of family docs or nurse practitioners or PAs. The other additional things they do in the women's health clinic is some colpo and more MVA and EVA for termination. Our philosophy when it comes to family planning specifically is opt out. We feel pretty strongly that residents shouldn't have to use all of their elective time to get trained in something that is pretty important to most patients and impactful in a family life over time. Our focus is on medication abortions, and the reason for that is that when you look at studies of practicing family docs, most of them do medication abortions. There are a subset of people that are working specifically in family planning clinics or have a focus on family planning, doing a lot of aspirations or terminations or office or OR-based procedures. So our default curriculum is to get competency in Med-ABs with exposure to aspirations. We have essentially an untapped opportunity for lots more aspirations, and I think residents that are interested could certainly get lots and lots of numbers. There's basically 2 OR block times per month for second trimester D&Es or first trimester procedures that have medical complications that the residents are welcome to participate in. Again, that would be more exposure. We're not going to train anybody to competency for a 22-week D&E. In terms of innovations in our curriculum, we do a prospective panel management with contraception in mind. So one of the things that we can do in our system is for any number of illnesses, we can have the electronic record pull all the data for your patients. So if you're doing a CHF or COPD workshop, you can pull all of your COPD patients. And in the process of the learning about COPD, you can also do some panel management work. And we felt that contraception is part of that, and pregnancy intention and family planning should be considered. So what we do is we pull all the reproductive age females 15 to 45, and we do a contraceptive workshop for a couple hours during protected didactics, and then you have some time to go through your list of patients and see who it was that you had talked about family planning with that kind of got lost to care, or you just missed the follow-up or whatever. And it's a chance to really kind of think about family planning and pregnancy intention prospectively, as opposed to when somebody's pregnant and doesn't know what they want to do. In terms of other innovations, we were a recipient of a RAP Miscarriage Care Initiative grant that was resident-led a couple years ago. And as I mentioned, we are in the process of rolling out medication abortion into our clinic. I've been really hoping to have resident leadership in that just for a leadership experience. So I don't know if that's going to be one of our current interns, second years, or one of you. But I'm not going to wait if nobody gets around to it. And so the other way, for those of you that are more like graphic visualizers, here's our family planning specific curriculum. We train all the interns in IUDs and get implant certified during orientation, so that nobody has a patient on their schedule that they can't take care of even in July. In the R2 year, we do a miscarriage care workshop, a papaya workshop for aspirations. We do a colpo workshop. During the R2 month, as we mentioned, there's a fair bit of office-based GYN care in addition to medication abortions and DNCs, and that OR block time for those that are interested. Plenty of room for electives in the R2 and R3 year, and that can be OR time or more procedures. I mentioned the procedure clinic in AFM. We think it's really important for people to see family docs doing family medicine. And then we have Thursday didactics. That was really all I had. I want to give the other faculty a chance or the residents to jump in and see if they have anything pressing that they wanted to share. This was meant to stimulate some discussion and see if you guys had any questions. I don't really want to talk that much.
I think it's important to note, if people aren't reading the chat, that Dr. O'Connell just plugged Dr. Flaxman in terms of being the editor of the Teach Early Abortion Training Workbook, of which many people have used. And I learned specifically how to do early trimester abortion training from that manual. So thank you, Gabe.
Thanks. For those of you that aren't aware, Teach Training is a great resource to teachtraining.org. And I hope that you'll enjoy it. It's a big collaborative effort.
I had a question. Hi, I'm Gabriella. I'm a fourth year at UCI. And I was wondering about procedures. When a patient comes in and they want an IUD or an Explanon placed, are they always scheduled for the procedure clinic, or are they also scheduled with their primary family medicine?
No, that's a great question. So the procedure clinic is meant to be actually a resource to our adult and family medicine department and our women's health colleagues outside of the residency. So our women's health, which is the name of, in our system, that's basically the OBGYN office, is busy just like everywhere else. And so they are always looking for places for appointments. And so we have kind of set up with them, if it's a patient who doesn't care who they see or they want to see it as soon as possible or their doctor isn't around, they route their patients into our clinic. And our adult and family medicine colleagues will do the same thing. But I would never want, for like Gabriella, if you were in our office and you had a patient with an Explanon or an IUD or wanted one, I would encourage you to book her in your clinic. So this is in addition to, not instead of.
Great, thank you.
And Gabe, can I just add in on, can I make a comment as well? Just yesterday, I actually had one of my own patients come into my clinic and we put in an IUD. And the prior Friday to that, I actually precepted the GYN clinic with another resident. So there's lots of opportunities to do GYN procedures within the clinic, your own clinic, and then within the GYN clinic.
Great, thank you.
I have a question, if I may.
Yeah.
So I understand the population that the community that we serve is like very diverse. It's one of the most diverse in the nation. And given the historical trauma associated with a lot of GYN procedures, does the curriculum also teach people about like forced sterilization and how to approach certain cultures from a like sensitivity point of view? I know like you guys do diversity and inclusion workshops, but do you take that to the next level, especially regarding GYN?
Yeah, it's a good question. We're actually in the process of, this year has a whole, essentially it's a half day of protected block time for the resident that's on GYN to do some reading and watching a couple of videos and reflection on reproductive justice. And then it's not really a graded reflection, but just a kind of chance for a discussion. One of the challenges in our population, and Patrick or Kathy may echo this, is because it's so diverse, it is very challenging to say, oh, I really can start to understand, you know, the cultural implications of being a first generation Cambodian refugee community where all these kids are here, or I'm taking care of patients that are all from this one, you know, part of the Navajo Nation or one part of Mexico. And we have patients from all over the place. And so I think we really try to focus on a lot of cultural humility, but we do a lot of teaching around, you know, language in the exam room. And I'm hoping that a combination of both group discussion and then a little bit of personal reflective time that's protected will address at least the provoking thoughts on this topic, which is ongoing. I hope that answers your question, Tristan.
And actually, of interest, we do a literature and medicine sessions within our Thursday didactics or after hours. And one of the readings we just shared handled the exact scenario you're talking about. I think you're referring to Dr. Marion Sims, who did a lot of experimentation on the slaves and perfecting his repair of the trauma during childbirth. And we actually used a poem that spoke to that very topic, and we discussed within the concept of you know, I mean, trauma and you know, racism. And so yes, I mean, I think it does come into the curriculum in different ways. And then can I'm up on labor and delivery, and I'm going to put AJ on there. Can you see AJ as well? So we are on labor and delivery together, and she wanted me to bring up that gyne procedures are actually done while they're on labor and delivery as well. They often will put in Nexplanons in the postpartum patient, as well as now we're doing post-placental IUD. So our residents are getting to do those as well when they're on labor and delivery.
Great. So unless any of the other faculty or the residents on this want to weigh in, let's really open this up to any Q&A. And you can either just ask your questions, or you can try to put your hand up and we'll find you. If you want to introduce yourself so we know who we're talking with, that's great. If you'd rather not, that's fine as well.
If someone's talking and you have a question, feel free to just put it into the chat, and then I'll help moderate.
Hi, can I ask a question?
Please.
Okay. So I was wondering if there has been any talk or any ideas of incorporating, you know, it sounds like there's a lot of great procedures offered through the procedure clinic and regular clinic, but, you know, follow up after deliveries with like postpartum depression, with other types of mental health that I think might be of interest with you know, delivering.
Natalie or Aime, do you want to answer that?
Aime, I think you're muted still.
You guys hear me? Sorry.
Yes, we can, Aime.
Great. Okay. Hi, Jemana. Thank you for the question. I'm sorry, Natalie and I are in the same office, so we had a little bit of that feedback. Yeah, I have to say that I haven't had the most experience with it, but I've definitely, I think, had enough where I've had the opportunity to learn more about it and talk to my preceptors about it. We I think we tend to see it, at least the way that I've seen it in kind of on labor and delivery, is that I've seen patients who've had a history of maybe postpartum depression or anxiety or something. And then we tend to work with a social worker. So most of those patients will be seen by a social worker to kind of assess them and see what needs they may have as they get discharged. And I just sort of, with those patients, kind of have taken that as an opportunity, because as a resident, you'll just have more time to kind of do things and to spend time with your patients. So that I've taken that as an opportunity to kind of talk to them a little bit more. I think it's also a great opportunity since we're always trying to promote residents to take on these patients after, either the mother to see them in postpartum and the baby too. I think it's a good way maybe to transition that care. So it's a good opportunity to be that bridge maker that often maybe some of the other obstetricians or the nurse practitioners that are on, the midwives that are on labor and delivery might not have that opportunity. So I think it's a good way to be a bridge maker, and it's one of the benefits of being a family medicine doctor. That being said, I don't know specifically kind of like how we would see that maybe more as an integral part of our curriculum, and maybe how we could develop that a little bit more. But I do think that just as a family medicine resident, you just have the opportunity to do so much more with that. Yeah.
There's obviously been a lot of change with COVID, and there's a lot of concern we have for sending new moms home with new babies, particularly if they had a traumatic or rocky delivery experience and they don't have the social network of people coming over, or are worried about having that social network like pre-COVID era. We have a couple of things, and as I may have pointed out, the benefit of family docs who are seeing the patients postpartum is we've transitioned most of our postpartum care to virtual, unless somebody's coming in for a specific reason, for a pelvic exam, a 3rd degree or 4th degree laceration, or if they decide they want an IUD and they didn't want it post-placentally. Those postpartum visits are all video visits. For the family docs, you're seeing a newborn baby at 2 weeks anyway, so you get to check in with mom. We have a virtual postpartum group through behavioral medicine that's very therapeutic for patients that are kind of struggling in the early postpartum blues, not quite needing medication, or that are as adjunctive treatment to postpartum depression. And our system is really nice in that comprehensive way that I can talk with a therapist. We have wellness coaches that do postpartum visits. That has also, again, I feel like a broken record. COVID kind of threw that for a loop, and I think it's coming back online. But they're nice. It's just kind of checking in, like virtual postpartum doula-ing almost. And we can talk more about OB, certainly, if you're able to come to the next one. And if people have more questions, we're happy to talk about OB too. I just want to make sure you all get a chance to talk about any office-based or GYN care you have questions.
I was wondering if maybe you could talk a little bit more about like colposcopy and sort of your pap smear colposcopy curriculum.
Yeah, sure. Why don't I give you an overview, and then maybe Aimee can tell you about the workshops and kind of her experience, because you got to do GYN month pre-COVID, right, Aimee? Kaiser Northern California is a huge organization with a pretty large membership, and so we create cervical cancer screening guidelines institutionally that are a little bit different than the ASCCP. The ASCCP tends to follow Kaiser Northern California guidelines or uses our data to make their own guidelines. So there is a slight difference, and we always have to talk about that with the residents, that, here's this organization called ASCCP and we use our own guidelines. And so we teach that because some people are used to looking at the ASCCP website. We have an algorithm that's very similar. We're moving towards primary HPV screening just like everybody else. The cervical cancer screening happens in our system for the most part every 3 years for routine screening. And then if there's abnormals, we have a computerized system to make sure that follow-up happens appropriately. And the follow-up would happen in the family medicine clinic or the GYN clinic or either one. In terms of colposcopies, they are done in the women's health office. The reason being is more the procedural back office staffing regarding tracking and keeping logs to make sure that follow-ups are done appropriately. We decided that it wasn't worth duplicating the system, and the residents could do some colpo in women's health. We actually bought a colposcope that's got a video monitor to allow residents to do a scope while I'm watching, or I can do the procedure while a resident is watching, so that they can really see what we're biopsying, even though we're going to do a 4-quadrant biopsy anyway. There's been an office change in women's health, and so that isn't happening as consistently as before. So I'd be curious to hear from Aimee if your colpo exposure was good, and you can talk a little bit about the workshop that we do specific to that.
Hi Sylvia. Thank you for your question. Yes, so I think that if you haven't attended one of our sessions before and you haven't heard about sort of the transition period that we have in between, as an intern and then in between 1 year to the next, we have sort of a month where we have the opportunity to practice skills that we might need for our upcoming rotations and a lot of other really interesting things that will prepare us for that. And as a first year going into second year, the colposcopy workshop is one of those that we get to do with one of our Dr. Lee, I think Justine Lee is the one that did the colposcopy session with us. And she's awesome. She is super dedicated to teaching residents and so friendly. I think that's also true for everyone up on our second floor. But in general, I did not have a ton of experience doing colposcopies as a second year. I think just in general, it's because it's one of those, we don't, personally, I think just in the future, there was the opportunity, I think, if you want to. I did not necessarily see that as something that I was necessarily going to integrate. So I think I got to participate in a handful of them, but I didn't necessarily go out looking for them. I think if I had, there was the opportunity to do that. And definitely, I think since we have so many weeks of elective, if that's something that you would like to do, I think you could create an elective where you could get more exposure to that. But I did not have necessarily a very robust kind of exposure to it, just a handful of yeah. Do you have any other questions, Sylvia? Anything more specific?
So if you feel like that was something you were really interested in, you feel like there's definitely enough opportunity. It's just maybe not your specific interest.
Correct. I think that you could. I know that we've definitely had residents who have graduated who had not even just colposcopies, but wanted more exposures with other procedures in GYN, and they've gone up and created their own electives to get that experience up on our GYN floor, where they just have more volumes of that than we do down here. So I think that, yeah, if you wanted to, you could have that exposure.
And Sylvia, I mean, we haven't had anyone who's really adamant about, getting a lot of colposcopy numbers in the past, but I would be pretty confident to say, if you're like, listen, this is really important to me, I'm going to go work somewhere where I'm going to be the colpo person, you would be able to get adequate colpo experience during your GYN month with some little heads up to me, and we can make your schedule work. I wouldn't be worried about needing to use a whole lot of committed elective time to get something like colpo training. The other thing that's nice about colpo is that there's a little bit of the mechanics of doing the procedure. And then if somebody hasn't been doing it for a while, you can go do, and later you find yourself in a new job where you're supposed to do a lot more. You can just go do an ASCCP course, and it's a pretty quick refresher. You're like, okay. I wouldn't feel confident that I could get you enough leaps without using elective time. It's certainly possible, but I wouldn't want to overpromise.
I think I'm seeing a thing in the chat here. Maybe Patrick, we're getting slightly
Yeah.
off topic, but talking about trauma-informed care and ACE's work.
Yeah, not necessarily tying into all the women's health procedures that we're focusing on, but trauma-informed care, all of our residents, all of our faculty, our entire organization at Kaiser Permanente is getting trained in ACEs screening, adverse childhood experiences in terms of screening, how to incorporate that training into our clinic, especially our women's health clinics and our family medicine clinics as well. And so that's one avenue that we're all really focusing on, trauma-informed care, because it sort of blends into every aspect of health.
Hi, this is Jody. I asked a question in the chat. I'm at Keck USC. Could someone speak a bit about what grads end up doing in women's health and women's health office procedures, sort of what like the average grad from the residency program ends up doing?
Yeah, that's a great question. And we do have, unfortunately, not a long legacy of graduating classes to give you numbers on. And you guys pipe up if I get this off, but the last graduating, going backwards from the first class, we had one who's a family doc at Kaiser who does full spectrum care. She's in more of a leadership role now. I was thinking about Violetta. She was the one that did our miscarriage care initiative grant. So she's doing a lot of routine office GYN and women's health at Kaiser down in Santa Cruz area. The rest of her class, I think one of them was debating whether she's going to be doing OB as part of her regular work in Arizona or staying in the Bay Area, and had been doing some locums work and then was having a baby. So I'm not sure what she's been doing yet, but she had done extra time with a plan to do OB. One of her classmates is on faculty at the new medical school and down in Kaiser in Southern California, and coordinates their sim lab. So she's doing like some regular clinical work, but not specific to women's health. So that's about half of that. And one of the other classmates is a family doc primary care in Kaiser in San Francisco. So I think that first class, it's about a third of the 6 of them is doing women's health. In the second class, one of them is actually works on labor and delivery, works in the hospital, and works in the women's health clinic doing full spectrum. So she does, I don't think that she's doing manual vacuum aspirations on her own at this point, but that was more because she was focused on OB and not necessarily for lack of opportunity. And then the rest of that class, Ted or Patrick or Kathy, I'm trying to think of who else is doing more office-based procedures. And
I'm just looking at the list. The other 5 in that class are all doing pretty broad spectrum outpatient family medicine that would include women's health and women's health procedures, not necessarily having a major focus on it, but very definitely. Then in the next class, Gabe, is Jelena Kelsey, who's doing OB. Kelsey, who's doing palliative. Sarah, who's doing inpatient. I can give you the names. You run the list.
Doing pretty full spectrum, yeah. Sorry, go ahead.
Then in the most recent graduated class, that group is all, Sean is doing rapid care, emergency department work. The rest of them are all doing very full spectrum family medicine. Allison Davidson just emailed me that she's joining the labor pool at
Alta Bates.
At Alta Bates, thank you. Yes, so incorporating OB. So we have a number of them who are doing OB, and a lot who are doing women's health in their practices, and a few who have an extra focus on women's health.
Thank you, that's helpful.
Yeah, Jody, so currently we have 3 of our formal graduates. It's about getting to like 1 per class that are doing
I apologize if you had
degrees.
mentioned this at some point and I just missed it. But I was wondering if you guys do vasectomies in the family
We currently aren't doing vasectomies in the family medicine clinic. We have been discussing whether we were going to incorporate into the procedure clinic on Friday afternoons. And it's something we may think about. The structure for vasectomies at our site has changed. It used to be that it was like a block of them all at once, and now it's kind of scattered throughout the day, throughout the week. And so there's some challenges to getting numbers to getting somebody to competency. So not currently, although there would be opportunity to try to create an elective, I don't think would be unreasonable. It's and I think there's probably a handful of folks that in the family medicine department that feel comfortable, and obviously less and less with more and more time. I think the vasectomy training is a challenge in general, and I would encourage anybody that's really interested to make sure that when you are looking, that you go somewhere, if that's something you want, that you spend your elective time getting it. Once you're out of training, it's very hard to get that without spending a fair bit of time and money.
Great. And I think we'll bounce back here. Patrick was about to say something, I think in response to Jody, and then there's a question from Shane Jones and from Karen Duenas. So Patrick.
Yeah, so what I was saying in terms of Jody's, we have, if you want to talk about from a labor and delivery standpoint, we have 3 of our former residents currently doing vaginal deliveries. And then 2 in our current R2 class are hoping to continue doing that and are considering OB fellowships.
Great. Shane, do you want to pose your question, or shall we pose it for you?
No, it's okay. I can speak. Hi, everyone. My name is Shane. I'm a 4th year at Michigan State. The question I had kind of revolved around point of care ultrasound, and I know it's not specific to just OB, but is there any opportunities for residents to get involved with that kind of training?
Maybe I'll take that one, since that was something that I was helping to lead. So the answer is yes. From the get-go, we have had very strong training in ultrasound for prenatal care and obstetrics. And just over the last 12 to 18 months, we've been building in point of care ultrasound into the inpatient arena, into our family medicine clinic, and then into our training, into musculoskeletal medicine, and even into the didactic sessions and workshops that we've held around that. Besides the Zonare ultrasound that we have for the clinic, we also have 4 butterfly ultrasounds that we use for training purposes and teaching and clinical care, inpatient, outpatient, musculoskeletal. We're really trying to get to the point now, I think as a specialty and at most programs, point of care ultrasound is somewhat experiential, where you get some exposure to it and it becomes part of your training. And I think that's true at a lot of medical schools as well that are doing it, where it's experiential, but not necessarily competency based. And so we're trying to look at it from that perspective and make sure you get the baseline training in it and the opportunity to view videos, and then do some hands-on, get experience in clinical settings and document that experience. And then on the tail end, actually have a competency assessment, so that when you graduate from our program, we'll be able to say, yes, Shane is proficient in these 8 modalities with regard to point of care ultrasound, just like we would with a knee injection and a vaginal delivery and an IUD insertion and any other procedure. So that's where we kind of see the ball moving. It's basically what the emergency medicine programs are doing. So we're working on getting to that point in our training. But the answer is yes, lots of opportunity to utilize ultrasound in your training, and I think plenty of opportunity also where it's actually built into the training.
Thank you.
Karen, would you like to pose your question as well?
Yeah. Hi, everyone. My name is Karen Duenas. I'm a UIC in Chicago, and I was just wondering a little more about the women health procedures. I know you said that you can use your elective time to gain more competency, but will that elective time would be within, the Napa-Solano hospitals, or do you have to go outside to a different institution to find the volume for competency?
That's a great question, Karen. And I'm assuming you're referring specifically to aspirations for first trimester. Is that right?
Yeah, or any, like you said, leaps or any of those
yeah.
procedures.
So I don't think that we would have a challenge getting anybody any procedures within our system, probably without much elective time, with the exception of aspirations, either for miscarriage or for termination. And we have two kind of set opportunities for residents to do additional procedures. The first is at Kaiser Richmond, which is, for those of you that aren't familiar with the areas, it's about a 20-minute drive when there's no traffic down the road. They're affiliated with Kaiser Oakland OBGYN department. And so they have a family planning clinic that does a little bit higher volume first trimester procedures. And they're very happy to have our residents come join for first trimester procedures, provided that the second trimester procedures are for their GYN residents, and that seems reasonable to us. In Vallejo, we have 1/2 day a week of scheduled office-based procedures, mostly with an electric vacuum aspirator. Unfortunately, those happen to come on Thursday afternoons, which is our protected didactic time. For those people that are on their GYN month, if they're interested in participating or doing procedures, it's an excused absence from didactics. It's just unfortunate that you have to decide if you're going to go and go to procedures and miss out on like a knee pain didactic followed by a headache in kids didactic followed by whatever. So you kind of have to make that choice. And that's just an unfortunate reality of scheduling. In terms of elective stuff, what we decided was if somebody's going to go to Kaiser Richmond or outside of Kaiser, we really want to make sure that that time is optimized. And so we said you're going to do four clinics within our system to make sure that when somebody goes, they can really hit the ground running. And that mostly when they get somewhere new, they're just learning the parking and where the bathroom is and not so much the fundamentals of the procedure. And so that's one opportunity. And then the second opportunity is when the residency was just getting started, we built a relationship with our local Planned Parenthood. And we had a nice system all set up for residents to go. And it was, and then nobody utilized it for the first year or two. And the doc that I was working with when we set it up has since retired. And then obviously there's a bunch of political and COVID type changes around the organization. And so I kind of, rather than keeping a system afloat that may not be pertinent to what's needed anymore, we let that go. And as soon as there's an interested resident, we will resurrect. Part of the reason for that, I think, and this is a little bit of a historical tangent, is, we're a fairly new residency program. And when the program initially started, it was started as an opt-in training program for no reason other than there was a lot to do in terms of setting up a program. The effect of that was that our first and second classes, who were kind of cutting edge applicants who were really ready to form a new residency program and help create curriculum, chose in that setting. And many people may have chosen to go somewhere else that was opt out. And so in the first couple years of our residence, we didn't have anyone, while we had people cutting trail everywhere in the curriculum, there wasn't the focus all the way in family planning. And so it's kind of an untapped opportunity and it's there for somebody who wants it. In terms of procedures in that half day in Vallejo, it's about 4 or 5 procedures in a half day. There's when I'm in women's health clinic, I often end up doing an MVA, sometimes 2 in a half day unscheduled. And if somebody said they were really interested, Karen, if you said I really want to do this, when you're on your GYN month, you could tell people, and I'd say, hey, I have 3 IUDs today, come do them. And it's not infrequent that the OBGYNs are like, hey, where's the resident? I have like 4 IUDs today. And it's just a question of timing and being in the right place at the right time, if that makes sense.
Awesome, thank you.
I see a question here from
BB. Yeah.
BB, I hope I pronounced that correctly. It sounds like there's an opportunity to talk about Allison Davidson's teen STI work with regard to her question. But BB, would you like to pose that so the group knows what the question is?
Sure, thank you. Good afternoon. My name is Bibiana, but BB. I'm a 4th year at MD and PH at St. George's University. And yes, that was my question. In regards to women's health, any disease prevention or health promotion, not necessarily with STD, but overall any activities or any outreach programs or any sort of patient education that you're implementing right now?
Aimee, do you want to take this?
Sure, yeah. As Dr. O'Connell mentioned, so Allison Davidson, she graduated with the last residency class, and as part of her quality improvement project, she and I think it was Sean too, both tried to address this. And so we, as part of our family medicine and resident clinic that we have here, we were basically just trying to see sort of the prevalence of gonorrhea and chlamydia. And so we were just doing like general screenings, and she had trained the medical assistants to basically just make it kind of a default. Anybody that was met like the criteria, like I think it was like 15 years or older was just getting screened for that. And so she did both a didactic session to train the residents on that, and then kind of gathered that data. We do have just kind of the way that our system works in general, the Kaiser system, we're a very integrated system. So we have a lot of outreach opportunities. And I think Allison and Sean were just, their interest aligned with that, and they wanted to kind of see how we could make, I think they were specifically wanting to target the adolescent population just because we want to make that a more visible presence in our clinic. And so we do have that as an opportunity to do that here. And I think like in everything else, if you have an interest, there is definitely support and a lot of staffing to kind of help you along that path. And if anybody else wants to add anything about any more details about Allison's QI project, feel free.
That's great. I see a question from Archana. I hope I pronounced that correctly.
Yes, thank you. Hi, thank you everyone for hosting this. My name is Archana Reddy from UC Riverside. My question was just regarding like community outreach and what opportunities there are for women's health, family planning, any organizations the residents are involved with, or possible opportunities that we'll be able to partake in. Thank you.
Gabe, Patrick, you want to weigh in on that? Or even Aimee talking about what's going on out in the community that you've been involved in related to that?
I can start on that question. I think it's a really great question in terms of community outreach. From our resident perspective, we have our residents going out to La Clínica de la Raza, which is a community health center, and they're embedded within their clinic, and they're also doing procedure clinics there. Within each class project as well, going to do more community outreach with the schools in the Vallejo Unified School District as well. Our current R2 class is really focusing on patients that are here within Kaiser doing centering pregnancy in terms of women's health and getting exposure there, and then tracking longitudinally what effects will happen with that.
Yeah, so when most of my exposure to women's clinics, specifically at La Clínica de la Raza, has been when we are on our outpatient surgery rotation. And so as part of that, that basically is just like a procedures clinic. And so during our week, we have one day where we go to La Clínica to do a procedures clinic there. And part of that does include a women's procedure clinic. Aside from that, I don't know if they have their own specific days, but I do know that they have Great Beginnings, where they have their own kind of obstetrician that follows their prenatal patients. But I haven't really gotten involved with that myself.
When we initially did our miscarriage care initiative grant, there was two purposes, and because we have a really good working relationship with La Clínica de la Raza in North Vallejo, we had said, look, we need a little bit of nudge to get institutional support for rolling out miscarriage care within family medicine, and also our partner, organization here at La Clínica doesn't provide these services, and there was a Planned Parenthood in Vallejo. There still is, but it recently stopped doing procedures, mostly because of a lack of need. In the Bay Area, particularly, you know, where there's readily available, highly effective reversible birth control, we're seeing a decrease in the need for procedures across the region. And so Planned Parenthood and Vallejo stopped providing aspirations. What that means is for patients at La Clinica who have a miscarriage and opt for an aspiration, they need to drive to Fairfield, which is not far, but it's unfortunate. It's, you know, it's a 15-minute drive from, you know, ish. And so we had tried to roll out the miscarriage care initiative to say to La Clinica, if you have a patient that has a miscarriage and would like an aspiration, that we can provide that service as part of a collegial interaction between the two medical centers. And unfortunately, they were kind of so overwhelmed with what they were doing and change in their leadership that they were unable to kind of wrap their heads around how to make that work. It's kind of a standing offer, but I don't know that they'll take us up on it. So that's more specific to women's health procedures. You know, one of the, I think the school-based, you know, the pediatricians and nurse practitioners that go to the school-based clinics, it's probably been a little upended by COVID as well, sadly. But we do, you know, we do also provide that support with peds. So if there's a patient that's wanting birth control in the peds clinic here, not so much at the school-based clinic, but here, they can just send them over, if particularly for IUDs, when the pediatricians are comfortable doing Nexplanons, but they get a little squeamish about an IUD, so send them over and we'll take care of it.
That was very helpful. Thank you so much.
It looks like we have a few minutes left. Does anyone have any last minute questions? Firstly, we just want to thank everyone for being here. You guys have really great questions. We're really excited to see every one of you, and look forward to seeing some more of you with interviews and some of our other open houses that we have coming forward.
I was just curious regarding the drive to the Fairfield, if I said the name correctly. Do we provide opportunities for the patients to get there if they don't have transportation, given the aspiration's not necessarily within the clinic that Kaiser Permanente has?
Well, so I may have, sorry if that was unclear. So for Kaiser patients, we'll do a procedure in our clinic, in the GYN clinic. I'll do a procedure at 3 in the morning in the ER if that's what the patient wants and they happen to be there. That's not an issue for our patients at all. This is more in the setting. La Clínica de la Raza is a federally qualified health center that is completely separate from Kaiser, and the residency has a relationship with them. But not in any way where we're going to tell them what they do with their resources or their patients. So we just try to be supportive and helpful where we can. They're working really hard. They don't have in-house ultrasound. So if a patient has a pregnancy, you know, early pregnancy bleeding, they're going to send to either the ER or formal radiology for an ultrasound. If the patient wants miscarriage care and the provider feels comfortable giving misoprostol, they will. But if the patient opts for a procedure, they would essentially be leaving that healthcare system and going on their own to Planned Parenthood, which is unfortunate. If they had no insurance, then we have a system in place through Kaiser where we could take that patient right into our clinic and take care of them. But unfortunately, community health centers are complicated, but they get reimbursed at a much higher rate to take care of somebody. And so if we start to take care of their patients, it actually hurts their bottom line quite a bit. So we can help with the uninsured patients, but like we don't have, that's like if they're going to send a patient up to Fairfield to Planned Parenthood, it would essentially be totally unrelated.
Sorry for my misunderstanding, and thank you for the clarification.
Oh no, it's fine. It's unnecessarily confusing, and I wish it wasn't so confusing.
Okay, so it looks like that is most of the questions. So, you know, if you do have any that come up later, we're going to have a general Q&A at the end of the interview season. We have another one scheduled around OB specifically. So please do feel free to hold those questions. You can also feel free to reach out to us by email, and we're happy to either respond that way or pick up the phone. We really want you to make the most informed decisions possible about your residency training. So thank you all for taking the time out of your lunch if you're West Coast, or afternoon if you're elsewhere in the country. We appreciate your interest in our program, and look forward to continuing the conversation with you at future events and interviews.